So live Zoom audience, see if we can get this thing to work. So we are surrounded by some in-person residents from our inpatient clinics here at the university. And we're going to do a case conference, sort of like we've done in the past. None of the residents in the room know the case, and they're going to help us walk through it in real time. So I'm going to go ahead and present the case. If anyone has any thoughts, feel free to add this to the Zoom chat as we go. Otherwise, the residents in the room are going to help us solve this one. This case is a combination of kind of a lot of diagnosis and then some management at the very end. Okay, so for everyone in the room, you guys will be admitting residents for an overnight shift in the DH NICU. You're called at midnight by the ER to admit a patient. So the patient's chief complaint, they were found down by a friend. Your HPI, the 28-year-old man with no prior history, found down in his apartment. History is obtained from the patient's friend and parents. One day prior to presentation, the patient called his father and said that he was not feeling well. He thought he was coming down with the flu. He began vomiting and had diffuse abdominal pain. On the day of presentation, the patient continued to throw up and couldn't drink anything, including Gatorade and light fluid. Over a 6-hour period, the patient's father and friends could not reach him by telephone, and a well check was performed by the patient's friend. EMS found him unresponsive and with labored breathing. He was subsequently brought to the DHER for further workup and management. All right, so for our residents in the room, what do you guys think after this initial kind of first piece of history?
Yeah, it doesn't sound good.
All right, great. So we've established this man does not feel well. Jonathan, as a kind of new intern, what's kind of your thought process for that brief HPI so far?
Can we make it a little bigger? To be honest.
Yeah.
But I was found down after like these young guys. Anybody was young and found down? I was in Cheshire. I just think you know about underlying medical illness, toxic and really high like differential here.
Awesome. So what else for our upper level residents? John, that's a great start. For our upper level residents, what else do you guys think of when you hear that pound down differential?
You think about other causes like alternative status like sepsis or meningitis or infection, NOS or like other maybe like a trauma that we don't know about, like a intracranial bleed or something.
That's great. Anything else you guys have on this list? Any kind of broad buckets?
Metabolic, sugars.
That's great. And when you say sugars, tell me more about that.
Hypoglycemia, I don't know if you have diabetes history or taking too much insulin, or new, especially a 28-year-old, he could be a new type of diabetes, no prior diagnosis.
Perfect. Yeah, so take some of your clinical history into account, like 28-year-olds should not become critically ill. And so what are kind of our things that push 28-year-olds into critical illness? But I think this is great. I think you've got your found down differential. This is kind of the thing we all go through in our head. So a broad tox problem, infection, trauma, intracranial issue, metabolic. And then the only other thing I would add to that, I think, and this might be, May's future career is cardiac. Yeah. And so does this person have an arrest? Do they have syncope? Something intracardiac?
I presume they have a pulse when they came in.
He did have a pulse.
You know, this
man's heart is beating right now.
Yeah. I mean, the other thing I'll put in there, it's not going to show this history because it's not okay in general, but new seizures can also associate with periods and that's any neurological cause as well.
What does say with history is like a week of a viral kind of syndrome, so virus, myocarditis.
Perfect. So kind of like generally any myocardial issue. Awesome. All right. So let me go ahead and give you guys a bit more history here. The Corey will share the whiteboard back. So a little bit of additional history provided by the family in the emergency room. Over the past 3 to 4 months, the patient had reported difficulty consuming any alcohol or beer. He said every time he tried to drink alcohol, he got very ill. He said that over the past few months, he's had an increased appetite. However, he continued to lose weight, approximately 20 to 30 pounds. In a startling turn of events, the friend's patient at the bedside pulls up his Instagram account and cycles through pictures from the past 5 months, which show the patient slowly shrinking in size and muscle not working out as frequently because he did not have energy. All right, so some clarifying history for our 28-year-old guy. What do you guys think?
Going more like down like the metabolic road, very, very much.
And Andrew, tell me more about like the metabolic road. Like what?
I mean, he's hypermetabolic for some reason, either with, it could be maybe like some global malignancy or something that he's been causing a little weight. We don't know if there's like other B symptoms, but definitely in like a range for like lymphoma. And also, you were talking about like diabetes earlier as well. If you have uncontrolled onset diabetes, it would be odd to be over multiple months. Like, you leave that without PK prior to this, but definitely possible.
Yeah, you just talk about a couple things, three differential based on the timeline. It's 3 to 4 months. You don't really think that's ingestion as likely just because it just wouldn't present the situation. Other things to think about, again, like neurologic stuff, unless it's like a new metastasis or something like that, that's the other differential. But other things like seizures, stuff that you know, if it was infection would be less likely unless it's like a chronic, indolent, slow infection, so they potentially immunosuppressed. That's another possibility, but again, lower likelihood. I think I agree with you, like metabolic is highly overlooked right now.
I wouldn't take out all ingestion, like what if you can take out supplements, stuff like that, like
Maybe kill the liver over time.
amphetamines, drug intake.
Yeah, I think that's awesome. So I think you guys really, big things all of you talked about was time course. So you've got kind of an acute decompensation, but he was getting worse for a chronic amount of time. And so trying to tie together an acute decompensation with a chronic process that you guys are focusing on, metabolic processes, underlying cancer, indolent infections, and then I completely agree with Anthony, like, you know, is there an additional tox process, like something weird in this guy's history. All right. So I'm going to go ahead and present this way. I was the admitting resident this night, and I'm going to present the case as I sort of found out about it. So I'll tell you right now, in the chart, I did a chart review before I called the ER back. He has no past medical history. He has no surgical history. He has no allergies. And his friends and family say that he rarely drinks alcohol, has not had it in 2 months. He does not use drugs. They're confident about that. He has never smoked a cigarette or cigar in his life. He has no relevant social or travel history, and he's sexually active with a girlfriend of many, many years. So at that point, I looked at the labs in the chart, and we will start with the labs before we go down to see the patient. So for this, I'm going to go ahead and draw the labs up on the whiteboard, and we're going to talk through these one by one. All right, so the first thing we've got is going to be a CBC. We're going to have a BMP as well, and then at this point, I asked the ER to add on some stuff. So this gentleman's white count is 20.7, hemoglobin is 17.5, platelets are 290, sodium is 140, K is 4.9, chloride is 98, his bicarb is less than 10, so undetectable with Denver Health, which gives him an anion gap acidosis or an anion gap of greater than 32. His BUN is 30, his creatinine is 1.54, we do not have a baseline, and his sugar is 868. His LFTs were within normal limits. So, with these labs in mind, what additional labs do you guys want to tell the ER to add right now? For this, we'll go to an intern. So, CJ, what do you want to add?
Things I want to add would be like a lactate. He's got a metabolic acidosis, which to dive it down further, basic butyrate, given his elevated sugar. And then things I probably would want to check things like TSH and kind of some basic other things to evaluate other things as well, maybe some LFTs just to get a more full picture of his other organ systems, and his kidneys seem to be involved. Or start there for now.
That's all.
A dip on the white count, please.
Just dip on the white count, sure. Definitely do that. Anyone else have anything else they'd like to add to this? CJ's initial thoughts are perfect.
Can we do UA, yeah?
Cool, so Brady, what's the UA and LUA?
There's ketone, glucose, obviously infection in this gentleman with a white count and really high sugar, looking for some precipitating cause.
Perfect. So I think you guys all are in the nail on the head. So ABG from the VA, perfect. Yeah, we're gonna get a VBG because RT pushed back. guys are right. So, like, the things that you all keyed in on was, he's got a metabolic acidosis, a profoundly low bicarb, he's got a sugar of 868, and right away, I think all of you guys are thinking DKA. So, this man is DKA in one of their labs, so we need to get to confirm that or help us out. So, this man's lactate was 5. His beta-hydroxybutyrate was greater than 132. Normal at Denver Health is less than 2. His TSH is normal. His UA has 2+ protein and 3+ ketones. And his VBG shows 6.63, 23, and 3. So for, so for any interns or medical students that are listening, his pH is 6.63, his PCO2 is 23, and his bicarb is 3. Can one of our upper-level residents in the room just kind of talk us through the additional labs that we just got back and how that might have changed your thought process or kind of what you want to do next?
There's a couple key things here. One, importantly, this guy's very sick, right? That pH is at like battery acid pH level or something like that. It's low. And so you got to be very, very careful when you do that. This is somebody that you have to have like a lot of concern over. Somebody that may actually end up going on dialysis just because of that severe acidosis. In terms of thinking through the other labs, so the anion gap, you noticed that beta-hydroxybutyrate is super elevated. So again, more consistent with something that's producing a lot of ketones, like something like DKA, potentially. A lot of the labs do fit with that. I think that's what I lean to. And then looking at the creatinine, this person's pretty dehydrated as well, so they want to give them some fluids. That's kind of what I'm getting through all these labs. Just this guy's really sick.
And one other thing I think I would add to that is I'm actually surprised that his sodium is normal, and I'm really also worried about hyperosmolarity in him. And I think that's just something that we should consider, like a DKA, HHS, maybe like mixed picture, such as glucose of 868 is a little bit on the higher end of what I expect for DKA.
Yeah, Andrew, Schweiger and Andrew, great point. So Andrew mentioned his sodium looks normal. Do we think his sodium is actually normal, or is there something going on with this lab right now? Yeah, correct. So, Jonathan, you're pretty early in your intern year, but do you know how to correct that sodium? With ND-Cal. Great. So Dr. ND-Cal is on the phone. Does anyone have a way to correct it without Dr. ND-Cal? All right, sorry.
We got limited brain space today.
Limited brain space. So if you take the 140, so essentially for every 100 that your glucose goes up, your sodium goes up by 2, above normal. So a normal glucose is around 100, so this man's about 700 glucose higher. And so basically all you do is you add 14 to this, and you get a corrected sodium of about 154. And so that's kind of the back of the napkin way to correct someone's sodium. So correct, this man is probably hypernatremic and he has all these other lab abnormalities. All right, so then Andrew walked us into kind of the next teaching point here, which he was a plant in the room, didn't even know it, is that sugar is pretty high. And so how do we differentiate DKA from HHS?
In the main DKA is an acidosis and HHS is hyperosmolar, so that's kind of how I think of it, and there could be a mixed picture as well.
Okay, so pH and osms are going to help us differentiate. What else? Ketones, perfect. Two more things that are going to help us here.
Like mental status tends to be worse than HHS, it's more somnolent. Not that you can't be a DKA, but
degree of glucose.
Great, so glucose, and then bicarb as well. All right, so let's just go through these one by one and be very, very specific about how we're thinking about this, because this is an admission. The seniors will get a ton of at Denver Health throughout the during the year, and interns, if you have not admitted DKA yet, it's coming. You cannot hide from DKA. So DKA pH, right, is going to be low. What's our pH going to be in HHS? Yeah, so it's basically going to be normal. And so the cutoff value there is about 7.3. So if you have a pH anywhere above 7.3, unlikely to be DKA, right, because you're not acidotic. Second thing, osms. Like Andrew said, osms are going to be high in HHS. Osms might be high in DKA, but specifically in HHS, it's a hyperglycemic, hyperosmolar state. Ketones, which one are we going to have ketones in? Perfect, DKA, awesome. You should not have ketones in HHS. Like Andrew said, mental status kind of more prominent with HHS, but if you're sick enough, you can certainly have it in DKA. Glucose, going to be high in both, but higher in HHS, and bicarb, correct, going to be low DKA. That number is typically 18. And so right now, right, we've got enough labs in this gentleman that we can correctly diagnose him with DKA. Does anyone have any questions about the diagnosis in this guy before we actually go and save his life?
The only thing I would note is just exactly what Andrew said. It's kind of a stranger presentation for DKA, particularly with that sodium and the high glucose. It's just something to keep in mind. It's not your, well, we know from the pH of 6.63, it's not your cookie cutter DKA, but still, something to just keep that in mind.
Yeah, completely agree, right? That's a very, very high glucose that we do not expect to see, and I agree the story's a little weird. He's it's been 3 to 4 months. It's an odd story. So, I promised Dr. Kearns that I would preach something called the Gospel of Dka. Dr. Kearns' Gospel of Dka. When you guys hear a DKA story, like what's your algorithm or your protocol for figuring out why they went into DKA? Like what workup do you order, what history do you take, et cetera?
Infectious workup is probably like the biggest one. And then obviously just understanding their medication history, if they are previously diagnosed, and whether or not they're adherent to those medications. But I feel like 1, 2, and 3 in my kappa differential is some kind of infection that's taken them over.
We got a lot going on.
The 5 eyes. Dr. Kearns has told everyone about the 5 eyes. Yeah, so Brady's completely right. So infection's on there. History. What are you trying to find out in history?
Just in terms of like their medication adherence.
Because they're on.
Yeah. So as Dr. Kearns says, insulinopenia. So you're not taking your insulin, or B, you've never been on insulin and your body has no insulin left. And then what else are we? What are the rest of our 5 eyes?
Inflammation, like
Cool. So inflammation, and then again to Maeve's future specialty, ischemia or infarction. Anything that causes inflammation. 2 more. Ingestions. Perfect. Ingestions or intoxications. Great.
Decisions like post-surgery or impregnation is another one.
There we go. The one that everyone forgets.
impregnation.
Impregnation.
With an N.
Oh, that'll be good.
Impregnation. Cool. Yeah, so these are the 5 eyes of DKA, and honestly, I think all of us put this in our DKA note when we write it, whether we realize it or not. And so what you all talked about was insulinopenia. You're getting this from your history. Infection, you're getting your CBC, chest X-ray, cultures, all that stuff. Inflammation, ischemia, infarct. EKG, questionable whether you're getting a trope in these people. Ingestion, that's a history, and then a UDS. And then impregnation for women, right, get a beta HCG, something that we should order in any woman of childbearing age coming into the hospital. And so that right there, you've got some of that already with blood, with his labs. Are you guys interested in getting the rest of that stuff, or do you think we've got enough information?
Definitely get around this stuff.
It'd be nice to get that stuff except for the baby.
Perfect. This man is not of childbearing age. Okay, so I will send this one back to Corey here for a little bit of additional. All right. So this man's EKG was sinus rhythm with a rate of 90 beats per minute. His chest X-ray had already been completed when you were called and showed no acute cardiopulmonary abnormalities. He had had a CT head done on arrival, which was also negative. Troponin was negative. Cultures were drawn, and he received vancomycin triaxone due to concern for underlying sepsis. All right. So you guys have now decided, you're like, oh my gosh, I need to go down and see this person. He's actively dying in the ER. So his initial vitals on arrival to the ER, he was hypothermic at 33.6. His heart rate was 95. His blood pressure was 93/62. He was sitting 99% on room air, breathing 28 to 35 times per minute, and had a noted GCS in the ambulance of 4. All right, so for our, kind of our interns, you guys may not have seen so much DK yet, but for our upper level residents, what do you expect this man's exam to look like?
The GTS before. That's telling pretty much everything. He's going to be in there, he's going to be, hopefully he's going to be too small in there. Really big, deep breaths. It sounds like you're not going to get anything from him in terms of neurologic tests, but by the time you get down there, hopefully he has a breathing tube in him already.
Sorry, so I just watched that 1 time. Hopefully by the time you get down there, he has what?
A breathing tube.
A breathing
Yeah.
tube, okay. So, interesting. So how many people in this room, and interesting, how many people on the chat would intubate this person?
You gotta be careful. You gotta be very careful. I think the problem is with his pH being so low, you could have a fair intubation code. But
I probably would be careful because, like, he's probably compensating, or trying to compensate really well. He's not doing a good job, obviously, but.
And unless you keep up his respiratory rate, he's just gonna retain, and get even more acidotic, right, by intubating him. So I probably would defer and call but defer intubation for him.
Yeah, this is a great teaching point. This is something I think we probably don't talk about enough. But right, we all go through med school and we hear GCS less than 8 intubate. And I think that's kind of our reflex. Is if someone's GCS is that low, they should have a breathing tube. But you guys are actually completely right. This is like one of the most high-risk intubations. And actually something that probably we should avoid at all costs. And so, Brady, talk me through again why intubating this man is going to be bad. Or could be bad.
So he's using his respiratory drive to compensate for his severe acidosis. And so if you intubate him, we typically decrease their respiratory rate when intubating them, and the machine breathes for them. And so he won't be able to clear off that CO2 and will actually become more acidotic. I think I'm thinking about that correctly.
Yes, awesome. And so you're absolutely right. So when someone's Kussmaul breathing, they're taking huge tidal volumes at a respiratory rate that's faster than most people breathe. And so for people that are going to be future pulmonologists, if you do a rapid sequence intubation in these people, one of the drugs that you're going to give them is going to be a paralytic. And so if you paralyze this gentleman, what is going to happen to his respiratory rate and his tidal volumes for the period of time in which you're intubating him? Yeah, so basically he's going to stop breathing for a period of time, 15 to 30 seconds until a breathing tube is placed and the machine is breathing for him. In the time that that's happening, his PCO2 is going to rise, right, because he's not ventilating anymore, which means his pH is going to drop. And so right now this gentleman has a pH of 6.63. He's probably holding on to his last strand of internal pH, and if this thing drops anymore, he's probably going to arrest. And so if you talk to a lot of the pulm fellows, they'll tell you that there's some of the scariest intubations they've ever had have been in DKA people, and a lot of young people who end up on ECMO or kind of long-term cardiopulmonary support end up because they were intubated with DKA and then arrested. And unfortunately, the human body, Kussmaul breathing, is more effective than any ventilator can possibly be. Like, we will never be able to reproduce Kussmaul breathing with any ventilator setting. So I was an early third-year resident, and I actually recommended the ER intubate this person, and the ER attending graciously gave me this teaching point over the phone and told me that he wanted to keep the person alive.
I guess so.
He said, I'm interested in having this person be alive by tomorrow, which was the correct call. Okay, so you guys are right. So we go down to the ER to see him in person. He is generally ill appearing on exam. He is not sharing much history in the room because he's got a GCS of 4. He has markedly dry mucous membranes with no oral lesions. He's got no neck stiffness or rigidity. He's tachycardic with no murmurs, growths, or calluses, normal pulses. He's got delayed calf refill. He's tachypnic with deep inspirations, like we said, and Kussmaul breathing. His abdomen is not distended. He's not tender to palpation. And on a neuro exam, he has no focal deficits, but he's just very slow to respond, and really, he's a GCS of 4.
How's his pupils?
Pupils are normal, equal, and reactive. All right. So, we've diagnosed this man with DKA. We've decided that he's critically ill and he needs to be treated with something. What do you guys want to do to treat him?
fluid.
Awesome. So fluids and insulin. So I'll tell you right when you're about to put your orders in, we all get the Citrix Denver Health ER updates, or, Epic updates. Epic has gone dark. So you cannot order a DKA protocol. You're gonna have to treat this man yourself for DKA by building a protocol on the fly. I think this is something that we all probably have internalized and know a little bit about, but, it's something that we click so often that we should probably know exactly how to do it. Okay, so CJ, you said you want to give this guy fluids. So step one or something in this process will be fluids. What else do we want to do? Insulin?
Yeah. And one notable thing with insulin is if the pH is that low, your insulin's going to denature. You're actually not going to be getting much efficacy with your insulin. I actually learned this the hard way. So you can be giving a ton of insulin and it's not going to do anything. So a lot of times with the pH is this low, you actually would start a bicarb drip. This is like one of the very few times where we actually consider it.
So I think Trevor brings up a good point. Question of how do we treat this man's electrolytes and his acid-base status? Cool. So these are basically the three pillars of DKA management. And so there's the initial phase of DKA resuscitation, so I'll put an I up here for initial. There's the management phase of DKA resuscitation, and there's the ending. So when do we pull back everything and say this person's actually been treated? All right, so CJ, what do you want to do for this guy's fluids while you're standing in the ER next to him?
I think initially just give him bolus of fluid, like he's probably, with DKA, he's probably like at least 8 liters down, given how bad it is, if not more. So he's gonna need a lot of fluid, so I think I would just start by giving him some crystalline fluid.
Cool, and if you had to pick a crystalline fluid, which would you do?
I guess just LR.
Great. So you're gonna bolus this man LR, give a pick a number for me, how many boluses, how many liters do you want to give him right now?
2, like right off the bat.
Cool. So we're getting 2 liters of right off the bat. Awesome. Insulin. We're staying next to him in the ER. What are we going to do?
I think make sure we have IV access would be good, a lot of IV access, and start probably insulin drip. I know.
0.1 units per kilo is what I usually do. Maybe at children, but.
With a 10, I think they usually give a 10 units, or 10 units.
You're getting better. A dose in infant.
Yeah, so actually, Andrew's exactly right. So the starting dose is still 0.1 units per kilogram per bolus. And then, Jonathan, which type of insulin do you want to give this guy?
Regular.
Perfect. So 0.1 units regular IV bolus. So a lot of times before we even get called, the ER will give this bolus to people. And so a lot of times we're starting the drip, but this person's already received the immediate resuscitation. And so for an average 70 kilogram person, this comes out to like 7 to 10 units essentially. And so you want to give them, if you're having a hard time calculating, I would just go big and say give them 10 units of regular insulin right off the bat. And then this man's electrolytes. What do we need to talk about, consider, or do? Okay, perfect. And Jonathan, do you have like a kind of a critically low number where you say hold off, we need to make it higher?
2, I think. Or the, I don't know the exact number where you wouldn't give insulin first. It's like 3.5. Oh, because it's a little bit higher. For like stopping.
Yeah, awesome. So just, you need to have a K higher than 3.3 to give insulin. And the reason is, right, if we give this man a huge dose of insulin and his K is that low, he's even lower in real life, and he's probably going to have an arrest because his K is so low. So getting his K higher, again, the ER will often do this for us before they admit them, but it's something that we should all know about. Okay, so you've given him 2 liters of LR, you've given him a bolus of regular insulin, his K was 4.9 or 4.8 when he came in, so we didn't have to worry about this. One of the really interesting things that I don't think I realized when I was, like until now, is the most important thing all these people should do first is get fluids before insulin. Because when you're hypotensive or you've got a low blood pressure, your body's response to that is to increase cortisol. And cortisol makes you relatively insulin resistant. And so just by fixing someone's hypotension and just by fixing some of their profound dehydration, you can actually drop their blood glucose by about 50 to 70 right off the bat. So without even giving them insulin, these people, like CJ said, should get at least 2 to 3 liters of fluid to decrease their underlying insulin resistance and sort of get them on track to be treated by the protocol. All right. So the ER has done this. They actually gave him 2 liters of fluid, and the patient actually woke up and started talking. And then, I kid you not, said, "See my Instagram," in quotes, for the weight loss. Yeah.
Documentation.
Documentation. He got his had 10 units of IV regular insulin downstairs, his K was okay, and we called renal, and renal said, treat this man with DKA. For DKA, we don't need to give him bicarb, we don't need to dialyze him yet, but they were appreciative for the call. Okay, so we've given this guy stuff downstairs, he's coming up to the ER, we still have to work our DKA protocol, so what's our maintenance strategy gonna be? We'll start with fluids.
You're going to eventually give D5. I don't know if you give it when the sugar's over 800, so you probably start with LR.
Okay.
Or normal.
So at some point, we're gonna have to give this man D5, so we'll figure out when that is.
Like under 250, yeah.
Cool. So we're gonna give him D5 when he's less than 250. And we'll talk about why that is in a second. But how much fluid do you guys wanna order for this guy?
Wow. Like, I mean, like 150 to 200 an hour.
Yeah, so Andrew does this a lot more probably with children.
Not 200 an hour, but lots of, we have a very good protocol where children's actually.
Yeah, and we have good protocols in our hospitals, but essentially those protocols involve giving someone 250 cc's to 500 cc's, depending on how hypoglycemic they are, per hour for the first 8 hours. So you're gonna give them a ton of fluid, and you're gonna keep resuscitating them. And then we're gonna start D5 when he's less than 250. How do we wanna give this guy insulin?
Infusion is.
Yeah. So instead of the bolus now, we're just doing this per hour. And then this is going to be one of those ones where the nurse is going to titrate for you. How much do we want to decrease this man's blood glucose by per hour?
I didn't know there was.
Yeah, that's great. Again, right, this is part of the protocol that like none of us see, but it's something that we're all like inherently doing. So you want to decrease the blood glucose by about 50 to 70 per hour until you get to that number right there. And the reason you're doing that is that the hyperglycemia is actually not the problem here, right? It's diabetic ketoacidosis. The ketoacidosis is the thing that's killing the person, and the hyperglycemia is just a function of being insulin deficient. And so the D5 is really to keep someone in that nice sugar range of like 120 to 180, while the insulin is stopping ketone production and closing their gap. And so that's why the D5 comes in, is you want to keep them level once they get under 250, while you're still treating the ketone. And then how do we want to give this person electrolytes, or what do we want to tell the nurse to do?
You're checking DMPs like Q2 hours. And then again, this maybe a children's specific thing because I haven't done this much here. We have like different, there's like a two-bag system with different, like one's with sugar, one's without sugar, and then the bags either have K or don't have K in it, or do have acetate or don't have acetate in it, depending on where they are in their electrolytes. Again, this is like done a lot over there.
And the potassium threshold is actually much higher, so even if your potassium is like in the normal range, you still gotta get to that.
Yeah.
Yeah.
I'm so glad that you're here for this all, right?
So we have a certified pediatrician in the room, which is incredible. But in the adult world, the nurses are going to give pushes of potassium chloride IV. And so what they do is they basically give 10 to 20 milliequivalents every hour. If the K is less than, generally about 4.5 or so, with a goal trying to keep their K actually close to 5 because you want to, they're overall potassium deficient. And then what other electrolytes? Dr. Kearns brings this up a lot on rounds. What other electrolytes do we need to worry about? Yeah, so mag and phos. And what is a phos going to look like in a DKA patient? Yeah, it's going to be low. It goes, so kind of similar to potassium, phosphorus, when you're insulin deficient, phosphorus leaves the cell. And so these people are often hyperphosphatemic in the ER, but the second you give them insulin, phosphorus shifts, and they become profoundly hypophosphatemic, which is what they've sort of been all along. And so oftentimes you have to replete the phosphorus as well. All right, so we're giving this man insulin. He's getting a ton of insulin. He's on an insulin drip for about 24 hours. When do we decide to end the insulin protocol?
Got to close any of them, keep those in his urine, depending on the NWS.
Stable insulin requirements. Yeah, greater than 17 or 18, whatever they.
Cool.
GMT told me.
So gap closed, bicarb greater than 17, and then stable insulin requirement. more about what GMT told you.
Oh, sorry, just for the bicarb. I feel like we don't always focus on the bicarb, but GMT is actually, pretty consistently will not transition them off despite having a gap, closed and a stable insulin requirement until that bicarb is above 17. Which has been kind of a new thing for me, when I'm admitting them to dealing with GMT.
Yeah, I think it's a super important point, that people have a higher chance of relapsing and going back into DKA if their bicarb is still low when we stop the drip. So I think that's an excellent point. A lot of times, we don't consult GMT on all of these people, and you just prolong an ICU stay if you take them off the drip too early.
Yeah, what's your thought about them eating before stopping their insulin drip?
Yeah, good question. So I know, it's right, so much of our training is who we work with. I know most of our attendings at Denver Health let them eat as soon as they're able to. I think some of the attendings here at the U are a little bit more cautious, but I think generally, it's recommended if the person can tolerate food, let them eat. And I think that's sort of, the humane thing is if a person wants to eat, let them eat. But, yeah. Okay, so does this person need fluids once we end the DKA protocol? Yeah, probably not. Hopefully we treated him enough that he doesn't need fluids. And then how do we want to end his insulin?
2 hours after a bolus is given.
Yep.
Yes.
Sorry, I said that really backwards. If Lantus,
Yeah.
wait 2 hours, turn off the drip.
Cool. And then Andrew does this a lot, so I'll stop picking on him. Just one of our medicine residents want to tell us how they dose the basal insulin.
There's two ways to do it. So I think the more accurate version is to find a steady state of insulin requirements on the drip. So I think if you look at the last 4 hours and it's a steady state, you basically multiply that by 24, and that's your total daily dose of insulin requirement. And then you split that in half. Half goes to long-acting and half goes into short-acting, and then your short-acting goes into third. Most people actually like to dose reduce that long-acting by giving 70% as opposed to the entire thing. Another way is to do it based on body weight.
Yeah, that's perfect. So I think there's two ways where you can do all the math and add it all up in your head and then cut it in half and do half basal, half short-acting, or you can take that steady state and sort of average it out, cut it in half again. But essentially, you're taking that 24-hour dose of insulin, giving half basal, and giving half as short-acting. And then electrolytes, right, ideally, we should not be treating electrolytes anymore if we fix this, because hopefully that problem is getting better. Excellent. So, some additional case updates for this guy, because you've now successfully treated his DKA. With no prior history of DKA, he does require a bit of additional lab work to figure out why he went into DKA. And so what other labs do we order for first-time DKA patients? Perfect. So the VA is saying GAD, which stands for, I think it's like glutamic acid, decarboxylase something. Glutamic acid decarboxylase.
Your anti-islet cell.
Perfect. So GAD's one of them. There's two others.
Anti-islet cell.
Yeah, so there's an anti-islet cell. And then there's also one called an insulin autoantibody. And then sometimes you'll also, this is sort of unrelated, sometimes you'll also see endocrine order a C-peptide level, just to confirm that they actually have no endogenous insulin production. So weirdly, in this gentleman's case, his glutamic acid decarboxylase was normal. His anti-islet, he never had it checked, sort of inexplicably. Something happened with the lab, but his insulin autoantibody was normal as well, and his C-peptide was undetectable. So he had absolutely no endogenous insulin production. Any questions about any of the labs that we order for the first-time DKA patients?
I'll just add on, we already mentioned in the beginning with his TSH, but I also do look for like hypothyroidism or like other kind of PTO or like other stuff that I'm worried about, other endocrine autoimmune processes.
Yeah, Andrew, I think that's a great point. We often don't think about like that whole constellation of symptoms because a lot of times these people are diagnosed before they get to us. But definitely, so checking TSH, which was normal in this gentleman, and then an A1C and all these other things to help us kind of figure out how long they've been diabetic for. Okay, so some case resolution. So this gentleman ended up having an A1C that was in the 12 to 14 range. He was on an insulin drip for 48 hours before coming off and requiring about 30 units of basal and short-acting. He was discharged from Denver Health after about 5 days, and for the last year has been doing well on lower doses of insulin, which speaks to the insulin resistance these people have when they come in. He still has no other medical problems, and overall has recovered. Perfect. So you guys just saved someone's life with DKA. You didn't intubate them. You created your own DKA protocol, and then we talked about the 5 I's for working up DKA. What questions do you guys have about DKA management?
Hey, Danny, one that I actually really didn't know until I actually got on the wards. I don't know if you want to talk about HHS management too, because that's one that we will do. Not as common as DKA, but
In that same vein, can I ask about the fluid boluses? Like, this gentleman had a sugar of 800, which I think you mentioned you would figure his like deficit was probably closer to 8 liters. I always get a little stuck of like how much to bolus them, and everyone says like 2 to 3 liters, but this gentleman would have been someone that I probably would have felt like needed 5 or 6. Do you bolus them 5 or 6, or do you start that 250, like 500, after 3 liters when they're like florishly volume down? I think that speaks to the HHS because they're typically far more volume down than our typical DKAs.
Yeah, really good question. So logistically, right, you can't just give someone 6 liters at one time to have IV access. And so, yeah, so this gentleman actually ended up requiring 6 liters of IV fluid in the first basically 8 hours. And so what some attendings will tell you is that if it's a younger person, if their heart rate is above 100, keep giving them boluses. So essentially younger people who have no like CHF or no ESRD, if they're still tachycardic and their mucous membranes are still dry, just keep bolusing. So essentially on top of your underlying fluid, that 250 cc's per hour, you can keep giving them additional boluses on top. Most of these people will eventually require 5 to 6 liters, but just not giving it all right up front.
Yeah.
But yeah, you're absolutely right. So essentially bolus based on, fluid responsiveness, straight leg raise, heart rate, all the things we usually do. These people are profoundly dry. And then Corey brought up HHS. It's a great point. So the underlying problem in HHS is that they've essentially urinated out all the fluid in their body, right? So they are even more so than diabetes or DKA. They're just really, really dehydrated. And so there's actually not great evidence for giving people with HHS insulin drips. The thing that they really, really need is they need volume, and they need the underlying issue fixed. And oftentimes, if you can fix the underlying issue and you can fix the volume, they don't need the drip for that long.
yeah, and I think one of the things it's one that you also have to be I didn't realize this until I did a patient with HHS. You also have to be very cognizant of lowering the sugars pretty steadily because they actually have. Usually they've been so hyperglycemic for so long, they've actually had I guess it's you worry about if you drop their sugars too low, and you actually worry about them getting, I think it's cerebral edema you worry about these guys. So that's another thing just to be cognizant of. Don't drop these people too quickly as well.
Yeah, and a really good question from the VA is people with ESRD or CHF, how much do you bolus fluid and what do you do? So you want to start out giving them at least some sort of bolus, obviously less, and then everything after that at a slower rate. And so, for instance, instead of 250 cc's per hour, maybe you're just giving them 50 to 100 cc's per hour. And I'll say that all of our protocols at all of our hospitals have 2 buttons you can push. One says no concerns for fluid responsiveness, and then one will say ESRD or CHF. And when you click that button, it will change the maintenance fluids and the initial bolus that they're getting. So, great question.
Yeah, good question for you. So you say talk to Reno, they just don't do a bicarb. What was the rationale for that? Because this is somebody's pH of 6.6. I would assume they want to.
Yeah, their reasoning was that it'll fix the number, but it's not gonna improve anything else.
Right. Did they not mention anything about potential insulin activity or anything like that? Last time I had a patient that was pH of 6.6, 6.7. Any insulin we gave didn't work, but it seems like it worked on insulin.
Yeah, so what they said was that he just needs tons and tons of insulin, and so we actually went off protocol for this guy, and we're giving him additional 10-unit boluses every hour in addition to the drip because he was so insulin refractory. And so their reasoning was that the answer to that is not giving him bicarb, it's just going so high on your insulin requirement right off the bat. That the bicarb is probably just gonna change the number, but he'll still have the underlying ketogenesis.
Yeah. I was gonna say, I'm not sure if it actually matters because the bicarb it's gonna end up being PCO2 at the end. You're gonna have to blow it off, but after it gets metabolized, it's gonna blow PCO2. So
right. It's just when you look at guidelines on everyday stuff, they always say for pH
protocols, there's an option for a drip, and they're supposed to call us if the pH is persistently less than 6.9, but renal said that they would not dialyze these people. But if you're dialyzing them, you're not giving them enough insulin.
That's right.
I think CJ made a good point about also giving him LR instead of NF.
Yeah.
And not giving him a concomitant like hyperchloremic, acidosis on top of his already metabolic acidosis, that was really good call.
Yeah. A plug for never giving any TCA in any situation. Please don't do it. And then also, right, we also hear about half D5, half NS, when you start cutting the rate. You essentially create that if you give someone a D5 infusion in one arm and the fluid in the other arm. That essentially dilutes out what you're doing by half. And so you don't actually need to remix the fluids, like none of our protocols have remixed fluids, we're just giving an additional infusion in the other arm.
This guy never had an infection, that was it was all just concentrated.
Yes, great question. So,
Yeah.
great question. So an interesting point is that the degree of leukocytosis in diabetes is typically like proportional to how high your blood glucose is, how high your beta hydroxybutyrate is. And so the higher your beta hydroxybutyrate, the higher your white count tends to be. And if you fix that, the white count will trend down at the same time. Cool. Any other questions about this case?